Well, thanks very much for the introduction and for the opportunity to be here and talk to you. Dr. Khanna and I are both very excited to share with you some of the research that we're doing at the university related to pain and hopefully how to manage pain more effectively. And why do we talk about pain? Because it's incredibly common. Pain is arguably the most common and most expensive public health condition in the developed world. As many as 100 million people in the United States have chronic pain. That is, pain that occurs on most days for at least 6 months. And the cost of pain to our society is greater than the combined cost of cancer, AIDS, and heart disease. So pain is a major problem that we really need to address. And of course, an important component in addressing pain is understanding more about it and doing the research to find the best treatments. So I've already given you the bad news. I'm going to give you some worse news. Pain is a major public health problem, and it's getting worse. The proportion of people in the population across all age groups and for both women and men, the proportion of people who have chronic pain has been increasing over the last 15 to 20 years. There are probably multiple reasons for this, but it's not the direction we want things to go in. The other bad news is pain is obviously impacting our quality of life. It's not enjoyable to have pain. It interferes with activity, but pain can also increase the risk for early mortality. That is, people with chronic widespread pain, on average, die earlier than people without chronic widespread pain. And we believe one reason that pain has been somewhat ignored as a public health problem is that many people say, well, it doesn't kill you like heart disease and cancer does. But in fact, there is some evidence now that chronic pain accelerates mortality. So there are all these reasons that we want to pay attention to pain. And so we're talking about pain, but pain does not occur in the abstract. Pain occurs in people. And I should say parenthetically, this is the height of my PowerPoint skills. It will not get any better than this, okay? So pain occurs in people, and people differ from each other in many ways. And the dimensions on which people differ from each other can sometimes determine how much pain they're going to have. That is, the differences between people can create differences in their pain experience. And that's what we study. We call it individual differences in pain. The formal definition is here: between person differences in the pain experience that are independent of the initiating pain stimulus. What I mean by that is if we do the same exact painful thing to everybody in here, everybody's going to experience it differently, because pain is an entirely personal and subjective experience, and we want to understand what contributes to that experience and to the differences in experience across people. Let me give you a concrete example. This is a graph of pain ratings after laparoscopic cholecystectomy. So people have had their gallbladders taken out laparoscopically. From 6 hours until 7 days after surgery, they ask people to rate their pain. Every little dot on this graph is an individual patient's pain rating, okay? And you see dots are all over the place. On average, 6 hours after surgery, pain was about 50 out of 100, right? So you might ask your doctor, how painful is this going to be? And they'll say, well, it's probably about a 50 out of 100, but that doesn't at all tell the story, right? Because a very fortunate group of people here reported no pain whatsoever 6 hours after surgery. A far less fortunate group of people reported pain of 100 out of 100 6 hours after surgery. And you can see people are occupying the entire range of pain experiences even after having the same exact surgery. This is individual differences in pain. And you may say, okay, well, the surgery was a little different for some people. People had different medications that they responded to differently. And so in our research program, we bring people into the lab and we provide the pain, okay? So we use a variety of methods to induce pain in a very controlled and safe and tolerable manner, but it allows us to know that we delivered the exact same painful stimulus to everybody in the study. So if they experience that pain differently, it has to be for other reasons, right? And even when we do this, we see individual differences in pain. Every white line here is a rating of pain of a 48 degrees Celsius heat stimulus applied to the forearm. You can see the average pain in that red line in the middle there is about 72 out of 100, so it's significantly painful for the average person. But you can see here, again, we have this group of people on the left who barely found it painful at all. And again, this less fortunate group of people on the upper right who found it exquisitely painful. And this is the exact same pain stimulus delivered in the exact same way to healthy young adults. And we see this wild variability in how painful it is. This is how pain works. This is not an anomaly. This is pain, okay? And this is what we're trying to study. This is also what led Sir William Osler, who's one of the founders of modern medicine, to say it is much more important to know what sort of a patient has a disease than what sort of disease a patient has, recognizing that characteristics of the person greatly impact how that disease will manifest. Okay, so I'm telling you that we study individual differences. Why would we do this? Number one, we think they reflect pain mechanisms. What I mean by that is the reason that people experience pain so differently is that different systems in our bodies are working differently. We have pain control systems, we have pain amplification systems, and these all work very differently in different people and differently in the same person over time. So when we see differences between people in the experience of pain, we believe that different pain mechanisms are operating and that if we understand those, we'll be able to address that in our treatments. The other thing, I didn't show you any data here, but I hope you'll trust me, that individual differences don't just apply to pain, they apply to treatment response. Give the exact same drug to 100 people, you'll get roughly 100 different responses, right? And that's for a lot of reasons, genetic and otherwise, but individual differences influence pain and they also influence how people respond to pain treatments. And then for researchers like myself and Dr. Khanna, if you don't study individual differences, they undermine your research, right? So if I'm studying a pain treatment and I fail to take into account how people are very different in their experience of pain, that's going to create so much noise in my data that it may look like my treatment did not work when in fact it did work. It's just that it worked differently for different people. So it's really critical from a research perspective as well. Now, we tend to think about these individual differences in pain from what we call the biopsychosocial model. And what this means is that we know biological factors are really important in driving the experience of pain, but they do not act alone. Our psychological state, how we're thinking, how we're feeling, and our social environment, how much social stress we're experiencing, how much social support we have. All of those things work together to influence the experience of pain. And we need to take all of these factors into account if we're going to understand pain. So I want to talk to you about some of the research that we and others have been doing here at the University of Florida, highlighting different factors that seem to be related to differences in the experience of pain. And we look at different population groups by sex and gender, by race and ethnicity, and by age. We look at different biological factors and different psychosocial factors. I'll just give you some examples. If we think about gender differences, this may be a busy slide, but you see two sides to this slide here. You see kind of a blue side and a pink side. This slide summarizes 46 studies, including over 1 million people, where they were just looking in the population to see how many people had chronic pain. And when you look on the pink side, that means more women than men had chronic pain. And if you look on the blue side, the little dots mean that more men than women had chronic pain. And you can see that almost all the dots are on the pink side, meaning that the burden of pain, the prevalence of chronic pain, is substantially greater in women than in men. So about 30% more women have pain than men. And this is just for chronic pain in general, answering a question like, have you had pain somewhere in your body more days than not over the past 6 months? Okay. Now, I talked about some of the procedures we do in the laboratory. So when we brought a little over 300 people into our lab and we conducted heat pain and ischemic pain, that's using a tourniquet on the arm, cold pain, sticking your hand in ice cold water, and pressure pain, pressing a blunt plunger against your skin, and measured pain threshold, that is, when did it first become painful, and pain tolerance, when do you want me to stop? What we see is that males in the blue bars, all the male bars go up, meaning higher pain threshold, higher pain tolerance, or lower pain sensitivity, and all the pink bars go down. In the laboratory, women are reporting lower pain threshold and lower pain tolerance. I recognize this is just one study that we did, but I can tell you that this pretty well summarizes the hundreds of studies that have been done in men and women. In the laboratory, women report higher levels of pain and lower pain threshold and tolerance. And there are many different reasons for that we might talk about, but we study this in the lab because we think this might be part of the reason that women are experiencing more chronic pain in the population, because their pain perception system may work differently. So those are the kinds of studies we've been doing. We've also been interested in how the burden of pain may differ for different racial and ethnic groups. We know from abundant research that individuals from minoritized groups in this country, primarily Black or African American individuals and individuals who identify as Hispanic, they report, when they have pain, they report greater pain and disability, but they also tend to get less treatment for their pain, okay? And those two things could obviously be related, right? And so one of our graduate students, Ivan Avon, years ago, did a summary of previous studies, 28 different studies, comparing lower extremity arthritis, very common in the population, how much pain and how much disability do people report, and what are the differences between individuals who identify as Black or African American and individuals who identify as white. And what we see is that the Black and African American individuals report higher pain, regardless of how we ask them about pain. They report higher pain. They report more disability or poorer function. And then when we do a functional test in the lab, asking them to actually do some things, they show poorer functional ability in the lab. So this is very consistent with what's been shown in other studies. And that led us to embark on our upload study, Understanding Pain and Limitations in Osteoarthritic Disease, where we were trying to understand what contributes to these racial and ethnic differences in pain. These are the same kinds of pain tests I just showed you that compared men and women. These are comparing around 300 African American and non-Hispanic white adults, all of whom had knee pain or knee arthritis. And what we see here is that our non-Hispanic white participants were showing higher pain threshold and pain tolerance, and our non-Hispanic Black participants were showing lower pain threshold and pain tolerance. And this is very consistent with their reports of clinical pain. Remember that African Americans were reporting more severe clinical pain, and in the laboratory, they're reporting more severe pain in response to these brief laboratory stimuli. An area that a lot of our group has been interested in is how pain changes as we age. You can see from a nationally representative sample here, this was published just a little over a year ago, that the prevalence of chronic pain, right, the proportion of people in the population with chronic pain increases pretty steadily as we age, right? So when we get to 85 plus, we have the highest prevalence of chronic pain. And that's also true if you only look at people who have high impact chronic pain. That is, they're reporting pain that interferes with their life activities. Again, that's more common as we get older. So we know this trend exists in the population. Now that's general chronic pain. The picture gets a little more complex when you look at different chronic pain conditions. For joint pains and neuropathic pain and lower extremity pain, we see that pattern. As we get older, it just happens more and more, okay? For other types of pain, like general chronic pain, there is some evidence that the prevalence keeps going up until we hit middle age or a little bit later, and then it may plateau a little bit. But actually, some pain conditions become less common as we age. Headaches become less common, TMJ pain, abdominal pain. So there appear to be different factors that are affecting different patterns of age-related change in pain. And we're trying to understand why this pattern shows up the way it does. And so, of course, as we like to do, we've brought people into the lab and perpetrated pain upon them. And one of the tests we do, we call conditioned pain modulation. So it's our test of how well your pain control system is working. So the first thing we would do is we would apply, let's say, a hot stimulus to your hand, and we'd have you rate that stimulus. You rate it 75 out of 100. Then we ask you to stick your opposite foot in painfully cold water. Okay, 2 pains for the price of 1 here. And while your foot is in the cold water, we ask you to rate that hand pain again, and lo and behold, it's much less painful. So your pain rating of the hand pain went down by 40 points. That's a really strong engagement of your pain control system. You were able to dampen that pain. And then when you take your foot out of the water and you rate the heat pain again, it goes back up to where it was, right? So this is how we test your pain control system when you're in the laboratory. And my colleague, Dr. Joe Riley, did this in a group of younger, middle-aged, and older adults. You see the younger adults got a nice decrease in pain here. The middle-aged adults lost some of that decrease in pain, meaning they're losing some of their pain control system. And the older adults showed no decrease in pain. That pain control system just never kicked in for our older sample, okay? And this is one of the reasons we think pain may become more common as we age, is that our body's ability to control pain diminishes. So when we think about pain, we think our ability to feel pain and how much pain we feel is based on the balance of what we call pain inhibition or pain reduction systems and pain facilitation or pain amplification systems, right? We need the ability to feel pain so that we can get injuries taken care of when we have them, but there may be times when we want to dampen our pain so that we can go on about our life. If those processes are in balance, then we have a healthy level of pain perception. But it looks like as we age, we get better at amplifying pain and we get worse at dampening pain, which may put us at risk for experiencing more severe chronic pain. I mentioned genetics and other biological factors. This is always an interest of people when we talk about medical conditions. It's sort of surprising that everything seems to have a genetic component. This is actually a study of twins where they identified how much genetic heritability there was to political attitudes. And you may be surprised to know that your political attitudes appear to be 30 to 40% genetic, right? And so when we encounter other people whose political attitudes are frankly moronic, we should have some grace and recognize that they may have a genetic disorder, okay? And just like political attitudes, pain has a strong genetic component. Back pain is a little over 30% heritable. Widespread pain is up to 50% heritable or genetic. Migraine, the same thing. And even the kinds of experimental pain tests that I've been talking about, those have a significant genetic component. So we know that genes contribute to the experience of pain. And I am a psychologist by training. I should at least talk about some of the psychological contribution, right? I told you about the biopsychosocial model. There is the biological component, but there's strong evidence from many different studies, and this is just a few fairly recent ones, many different studies that psychological factors contribute importantly to the experience of pain. And what's more, psychological interventions, behavioral interventions are quite effective at helping people manage their pain. And I'll tell you about some data from our OPERA study. And I guess I should pause for a minute. You've heard about our Upload study. You've heard about our OPERA study. We were also part of the Soprano study. We're conducting the ULTRA study. You get the picture. If we have a study, we want an acronym, right? It's one of the most important skills in clinical research. We have developed a clinical research acronym program, also known as CRAP. It's been very helpful in moving our research forward. So if you want more information on that, you can see me after the talk. But the OPERA study, this is a complicated slide. This was one of the largest studies of facial pain, jaw pain. Some of you may know people who have chronic jaw pain. It's one of the most common chronic pain conditions. We were trying to understand what are the factors that lead to the development of this kind of jaw pain. And so we recruited across 4 different sites in the country, over 3,000 people who did not have jaw pain and had no history of jaw pain. They were, by and large, healthy young adults. And then we followed them for several years, waiting for some of them to develop jaw pain, which they did, okay? And this graph shows you some of the psychological factors. Now, in OPERA, we looked at many different factors, biological, clinical, psychological, but this is just an example of psychological factors. So there were global psychological symptoms here, like somatic symptoms, lots of symptoms throughout the body, nausea, itching, dizziness, those kinds of things. Depression, symptoms of post-traumatic stress disorder, and then stress and negative affect, people reporting high levels of stress and anxiety and negative emotions. All of these factors predicted future development of this chronic pain condition. Again, we measured these things when people were pain-free. They did not have any pain. Months to years later, these factors predicted those people who were at risk for developing pain in the future. So this suggests that psychological factors are not only in response to chronic pain. Obviously, if I'm in pain much of the time, my psychological status would change. I wouldn't be as happy. I might be more depressed or more stressed. But this also suggests that your psychological functioning before the onset of pain might influence your risk for developing pain in the future. And I've shown you the biopsychosocial model already. One point I want to make about this is it's not just that we have biological, psychological, and social factors that add up to influence pain. It's that they interact with each other. And I'm not going to show you any particular data, but for example, there are genetic factors that contribute to pain, but they do so only in women or only in men, okay? There are also genetic psychological factors, for example, that contribute to pain, but only in people with certain genes, okay? So biological and psychological factors can interact, and social factors can cause biological changes. If you're exposed to a lot of social stress, that can alter your biology. It can cause you to have more inflammation. It can cause changes in how your brain is responding to things, and that can alter the experience of pain. So the biopsychosocial model can get quite complex, but that's what pain is. Pain is quite complex, and so we need to try to take all the factors into account if we're going to understand pain, if we're going to treat it effectively. So I told you a number of different things. What are the implications for pain management? First of all, pain is a highly personal experience. It's influenced by many different biological and psychosocial factors. Therefore, treatment needs to be individualized and multimodal, okay? Pain self-management can be highly effective. If you experience pain, there are things that you can do for yourself and things that you can learn that will be quite helpful in managing your pain. Arguably, the most effective pain treatment that we have, on average, is physical exercise. There have been studies that have compared exercise to several different drugs, and exercise wins, okay? The problem is, if you have pain, exercise hurts, so you may need professional help in designing and implementing an exercise program that won't aggravate your pain. But that's an important one. Stress management can be very helpful. Mindfulness meditation, relaxation, cognitive behavioral therapy. These approaches have been shown to be very effective in helping people manage their pain. And several of our research center members are now interested in nutritional factors. This has really been understudied in pain, but there's reason to believe that what we eat can greatly influence how our pain works in our body and can influence our levels of inflammation, among other factors that can cause us to experience more pain. So there is hope. I know Dr. Khanna is going to tell you about some of the drug development pathways, and there's hope in that as well. I want to just introduce you to our center, PRICE, the Pain Research and Intervention Center of Excellence. We've been around for about 12 years. You can see our vision here. In our organizational chart, my associate director, Dr. Cruz Almeida. And I just am showing you some screenshots of some of the studies that are up on our website that may be of interest to you, either because you want to learn more or you want to participate. Some of the studies involve interventions. Some of them are not treatment studies. They're just studies to help us better understand pain. We're studying many different chronic pain conditions, and we're hopeful that as we continue to pursue this work, that we'll develop safe and effective interventions that we'll be able to personalize to people and help them improve their quality of life.